Hi, my name is Associate Professor Joel Rhee, and Night is my favorite piece.
Morning, Joel. Thank you for coming here today for an interview, Blitz Chess Interviews. I'm going to play a game of 5-minute Blitz and we'll get to know you over that period of time. And then we'll do a bit of a post-game interview about your body of work at the moment.
Sure, yep.
All right, so let's start. You know how the clock works?
Yeah, I pressed the button.
Yep, that's right. All right, so e4, e5. So why is the knight your favourite piece?
It's because it looks the best.
Fair enough.
And it's there's some elegance about the knight, I think.
Yeah, I understand that. Yeah, so I remember the first time we played a game, you played the Ruy Lopez, and playing the best response to the Yanish Gambit, I see.
Oh, okay.
Oh, I think we forgot to press a few times. That's okay.
Interesting.
So you're you're professor, associate professor of general practice. Can you tell me a little bit about your role here at the university?
Yeah, so I'm the head of the discipline of general practice. So basically, responsibilities for teaching and research in general practice, in the discipline of general practice. So yeah, I lead a number of research projects, supervise higher degree research students, provide advice, I guess, when it comes down to issues relating to general practice and primary care, and a few other things. Yeah.
And by general practice, so for those of you who live in other parts of the world, that's family medicine?
Yes, that's right. So 4 different things, and so family medicine would be the North American and other countries, obviously, and obviously the role of general practice does differ in different countries. Yeah. So what's going on here? So you're pinning something and I'm pinning something.
Yes. Yes, you're making the Yanish not fun with the with this variation.
Oh, okay. I'm struggling to make sure I don't do this instantly. I feel that I need to do some exchanges. That's not good.
Interesting. Check.
Interesting. I see.
Not sure what you see because I don't see anything.
You're going for here.
If pawn's always a weakness.
I suppose I could always do this, but it's risky.
Mm-hmm.
You could sacrifice your bishop and see what happens.
Mm. Like sacrificing bishops, but that feels unwise.
It doesn't. Not be pinned down.
Fair enough. And what other roles have you got? Because I think you're quite involved in the Royal Australian College of General Practitioners as well.
Yeah, that's right. So I'm the chair of the Cancer and Palliative Care Network at the college. Also part of the expert committee in research and deputy chair of the ethics committee. And also, yeah, so that's my main roles there. So I take you.
Yeah, one of the advantages of the Yanish is you often get a semi-open F file, which nice tactic, but you sacrifice some material for that. Yeah, I guess that makes sense.
Interesting.
And if I recall, end-of-life care was the topic of your doctoral work. Is that right?
Yeah, so I looked into issue of advanced care planning.
31 seconds left.
Yeah. Only 10 seconds.
That makes sense.
There's only 2 seconds, so I'll lose. There's no hope.
Oh, there's always hope, I guess.
Yeah, it's gone.
All right, flags.
Excellent.
Good
All right,
game.
Excellent. Good game.
Yeah, all good, all good. So tell me a little bit more about the nature of looking after older people, so aged care. So you're a specialist general practitioner, or in sort of North America, a family physician. What's your perspectives on sort of the role of family doctors in looking after older people?
Yeah, so I think in looking after older people, it becomes an issue of not only looking after acute health concerns, but a lot of the work it does involve managing lots of we call it multimorbidity, lots of medical conditions. So, and these are often medical conditions that are even unrelated to each other. Because you can think of conditions such as heart disease, which is often linked to things like blood pressure or high cholesterol, and sometimes diabetes, or that kind of thing could all be interlinked. But in many situations with older people, you do develop diseases which are not even particularly interlinked, and so it becomes challenging to manage these conditions. And patients often talk about or joke, and I think they're semi-serious when they do joke about it, which is that being a patient, it feels like a job.
Yes.
Yeah.
Yes, and so multimorbidity being someone living with multiple conditions at the same time.
Yes.
And as you mentioned, as people get older, but that's actually even the case for younger people as well, that the combination of multiple conditions substantially increases the complexity of care.
Exactly, yeah. And it's a recognition also, I guess, of the fact that these conditions themselves have a significant burden on people and their ability to manage their day-to-day life, their ability to manage their, could be jobs, but often older people, they're retired. But in terms of managing their family life, their personal life, etc., it significantly affects that, but it's also the treatment itself. The fact that many of these chronic conditions means that you've got to see health providers like doctors and allied health staff or nurses on a regular basis. So many tasks that need to be done. So maybe you need regular blood tests or regular x-rays or ultrasounds or whatever, monitor. Various non-GP specialists that you need to see. So all of that adds to that burden. And I think one of the challenges of working with people who are older is how do you make sure that the burden of the conditions themselves is not is well addressed by treatments, and making sure that treatment burden doesn't outweigh the potential benefits in terms of effect on the actual condition.
Yes. So I suppose a naive way of thinking about health treatments is a very linear sort of way. So someone has condition A or problem B, and this would be a treatment of the person you could see. So you refer the person to this provider. And then another condition you refer to another provider. And in each narrow slice, that can seem to make a lot of sense. But when you live with, let's say, 5 or 6 different conditions, each of those conditions may potentially be managed by 1 or 2 healthcare providers. Suddenly, if you follow that sort of mode of thinking, you could be seeing like 15, 20 people, which is completely unrealistic.
Exactly.
And to me, now I'm of course a family doctor myself, that one of the great roles of medical generalism is to prioritise the care, so that where can things be simplified, where things can be consolidated, where every additional burden of care must have some sort of palpable benefit rather than necessarily just a theoretical
Exactly.
benefit.
Yeah, that's right. And often it means that family doctors and other generalists can often utilise their skills in looking after lots of different conditions, in managing lots of chronic conditions. And I think one of the interesting things about it is that non-GP specialists are often very good at managing specific conditions. There's no doubt about that. They're very well read up in terms of latest techniques, latest research evidence, that kind of thing, and they know exactly what the best way to manage a condition is. But often the family doctors and other GPs and generalists are very good at actually doing a good job as well. It might not be perfect, might not be the standard of someone who's dedicated decades of study into a particular area, but often they can do a very good job. And to someone who's got lots of medical conditions, sometimes getting your family doctor to look after those many conditions is much more preferable compared to seeing 10 different doctors, for different conditions.
Now, can you tell me a little bit about some of the research work that you've done, or is there something that you're working on at the moment?
Yeah, so there's a program of research our department is basically doing, which is around improving the way that we look after people living in aged care homes. So these are obviously called different things in different countries, but in Australia we call them residential aged care homes. And people living in there often, you sort of qualify to live in one of these aged care homes depending on your level of disability or your level of function. And most people who live in there are very frail, many have dementia and those conditions. They require a lot of assistance basically to live there.
So in other parts of the world, or in the vernacular, these might be nursing homes or retirement villages.
That's right, yeah. And so these patients do require a lot of support in terms of carer support, so personal care when it comes down to activities of daily living and that kind of thing. They also require a lot of support from a nursing perspective. For example, managing medications, and they might have wounds that require good care, nursing care and things like that. But they also require good quality medical care as well. And in Australia, GPs or family doctors are the ones who provide that day-to-day or continuing medical care for these patients. And it's a significant challenge for GPs because the resources that's available for doctors for people living in aged care homes is very limited. And that's a product often of the fact that many people living in aged care homes have poor mobility. Some could be actually bedbound and can't actually travel outside. And the reality is most healthcare services in Australia, and I suspect around the world, are mainly geared towards people who could walk into their facility. And so, even getting things like scans and ultrasounds, that can be a challenge. Getting healthcare services other than GPs, so non-GP specialists to see patients in nursing homes can be a huge challenge as well. So it's a massive challenge for healthcare system, and so our research is looking into ways to improve the way we look after patients in that setting.
Okay. And can you tell me how the study will do that? So how will you investigate this one? Because it sounds like it's very important trying to provide better care to older people.
Yeah, so there's a range of different studies that we're doing. So, for example, we conducted a number of interviews with people who live in aged care homes, as well as their families and informal carers, to explore their experience of receiving medical care in that setting. And they've told us a lot of really important ideas, and one of those, for example, is the fact that many people don't actually have they don't seem to have a strong relationship with their own GP. And the reason for that is because often the discussion of healthcare for residents appear to be mainly between the GP and the nursing and the care home staff, and often it doesn't seem to involve the residents or the family carers as much. So, and that's quite unfortunate. That's the case. And as a family doctor who actually looks after people living in aged care homes, I can see where that's coming from, because there's so much administrative tasks that doctors have to do in aged care homes. So things like filling in medication charts and doing those routine everyday things, most of your time is spent in discussing and talking to your care staff and nursing staff, and not enough time is spent in talking to the residents or their family and carers.
Yep.
So that's an important lesson. One of our medical students from last year, who was doing a year-long research project, actually, what she did was she went around different GPs visiting aged care homes, and she went around with a stopwatch, and she actually documented exactly what GPs do in aged care homes. And that was really sobering sort of results came out. And the reality of that was that majority of their time seemed to be spent on doing administrative tasks, and shockingly also even things like logging into computer. That took up quite a significant proportion of time.
Yeah, right.
And finding staff to talk to, just wandering around the nursing home, looking for the nurses or the carers to talk to. All of that took up so much of their time that there was insufficient time that they could actually spend in talking and examining and helping the residents themselves.
Yes. It's interesting because, time is of all the resources is non-elastic. You can't just make more time.
Yes.
There's only so much. But it is something that from a health services perspective is relatively difficult to measure. So if you look at inputs like financial costs, we've got very, very good systems to monitor that in terms of staffing. It's a notional. You can look at payroll. There's a whole number of ways you can do that in terms of goods and items. You can again look at sort of inventory and how much expenditure goes into particular items. But this issue of time, I think we see it in the community as well, and in some other countries, I think the US in particular, this phenomenon that increasing amounts of the fraction of clinician time being spent on administrative process tasks, but not direct patient-related care. Of course, processes are important too, not direct patient-related care. Does seem to be a growing experience phenomenon by clinicians. I would have thought that this also potentially provides a significant opportunity, because one could imagine that these process-related things, administrative things, which are often protocolized, might be something that could be improved quite a lot with new technologies, particularly AI-type processes. But what are your thoughts on that?
Yeah, definitely. I think there's obviously examples of AI scribes, for example, so they're not widespread in aged care home settings, but definitely in mainstream general practice in Australia and I suspect in other countries where AI can actually be listening in, obviously with patient consent, but listening in on consultations. And it can generate a summary or notes even for the clinician. And that could save a bunch of time even doing that. And AI could assist in things like even generating referral letters and other documentation, obviously. And that'll all require, obviously, the clinician to review and make sure it's all correct, that kind of thing. But still, it could save a lot of time. So I think AI is definitely going to be one of those potential time-saving devices. The other interesting recommendation that came from that study that I was talking about with the medical student is she actually, it was quite fortuitous that it happened, is that in majority of cases in aged care homes, the family doctors will go around and see patients in their own room, and that's how things are done. But in one doctor's case, when she was doing the observation, that doctor had access to a dedicated consultation room. And so that doctor's model was that the nursing staff and the carer staff would bring in patients and they'll actually see them in a private space. And
so you mean a private space in the aged care home?
That's right. And what was really interesting about it was that doctor, when when that doctor was doing that, the amount of time they spent on things like finding the staff or administrative tasks and other things dramatically reduced. So the doctor was actually spending a lot more of their time on actual clinic together with the residents. So that was really interesting, and one of the recommendations we were trying to make is, if aged care homes could provide a consultation room for the family doctor or other clinicians, that could actually be something that could dramatically change or improve the way we look after people.
Yeah, that's fascinating. Probably around 15 years ago, I used to look after around 35 residents in an aged care home, and that facility is now closed down. But we exactly had that. There was a clinic room as part of the facility, and generally I would see the residents I cared for in the clinic room. Certainly for some of the residents, they could bring themselves to the room. Others would need to be directed by care staff, and only a minority would I see the person in their own room. Usually these would be people who were basically room bound, so either due to physical disability, or maybe they're blind, or having quite severe dementia. But the majority of people would be in the clinic room, and I've never really entirely thought about, and I haven't done a huge amount of aged care work, but I've never really thought about that. That wasn't actually a very routine thing in aged care facilities.
Yeah, that's right. It's I think depends on each facility, doesn't it? Whether they have a consultation room. I've certainly been in aged care homes where they had a consultation room, but it wasn't equipped well. So and often it's sort of used more as an office rather than set up as a consultation space. And things like having a examination bed, often they don't have that available. Some nursing homes would, but others don't. And in fact, one of the other studies that another student actually did was he analysed lots of data, and what we found was that when older adults go into aged care homes, their skin cancer treatment drops off dramatically. And it's not as if they're getting any younger, because they're not. But when you look at the sort of time period before they go into aged care home, and when you look at the how many times are they getting their skin cancer treated, and when you compare that with once they get into aged care home, then there's this dramatic drop off. Some people will say, well, that's reflective of the fact that maybe that person's health has deteriorated, and that's why they're in aged care home in the first place. But I think it goes a bit more than that. And once again, I suspect that the reason for some of that would be because in aged care homes, there's not enough space where doctors can actually examine the skin well, let alone actually treat the skin cancer, because for that you need like an examination couch, you need good lighting. Like I remember trying to cut out skin cancers from people in their rooms, and I suffered badly because of back. You're hunched over trying to do this in bad lighting.
It's a bit heroic.
Yeah, that's right. It didn't go. Yeah, my back was not good, and so I never tried to do that again. And imagine that you just need better conditions basically to do the procedure. So once again, that's another example of our research, I think, highlighting some of the ways in which we could provide better care.
Yeah, and I suppose the concern is the very notion of someone moving towards supported living is that we provide the care for the older person, but is there a risk that this is actually just a representation of many other types or many other fields of care where we've actually created what's the right way to describe it? It's not discriminatory, but in fact that people have lost access to care by in a situation where they should have increased access to care.
That's right, yeah. And that's a really good point because so another issue which I flagged is difficulty of people living in aged care homes accessing non-GP specialist services. So one of the issue obviously is a lot of the non-GP specialist care in Australia at least, as you know, is delivered by private specialists. Obviously the public hospitals and their outpatient clinic does a heroic job, but it's heroic because there's not enough of them around. So a lot of that work is actually done by private specialists. And the reality is, and it's fully understandable, it's not a criticism of what they're doing, is that it's very difficult for private specialists to set up their clinic in such a way so it's accessible to people who might have reduced mobility and who might be in bedbound patients. It's next to impossible for them to even go to radiology to get a scan. So it's a barrier, a significant barrier. It's not their fault. It's not the non-GP specialist or radiology provider's fault, but it just basically makes access to those patients really difficult.
Well, these are system issues. Australia has, I suppose, a socialised insurance scheme through Medicare, but nonetheless, the majority of providers are still in the private sector. So we use a market mechanism and we can get market failures.
That's right, exactly. And obviously here the market failure would be because 98% or 99% of their clientele or patient base would be people who could, who are mobile or who could at least get a wheelchair, that they're set up that way, obviously. So a lot of that would obviously, the market failure would be addressed by public clinics and public system, but obviously they're really struggling, as we all know. So that's the other issue.
Now I'm going to ask, you've had sort of a long career working as a family physician, so specialist general practitioner with a specific interest in older person care. What major insights have you got in terms of what's important and how could things be better moving to the future?
Yeah, I think it's a matter of aligning obviously with the advancements in medical technologies and science and everything, AI and everything, a lot of things are possible, isn't it? And so I think the main challenge will be making sure that availability of these very high-tech treatments aligns with the values and the preferences of our older adults. I think that's going to be the key. And I suppose we're getting into the whole, talking about advanced care planning in a sense, which is around basically making sure that individuals can have say or express their preferences for how they want to be treated in the future if they are no longer able to voice, make a decision. So I think that's an important element, which I think needs, which is going to become more and more important, I think, because, maybe in the future things will change, but so far everybody dies.
Yes.
There's 100% mortality, and I think when we ask people how do they want to die, I think most people say, well, they want to die in a place of their choosing, and not. We commonly talk about people wanting to die at home, but that's not quite true, isn't it? So some people would say, I want to die at home. Others say that actually dying at home might make things very stressful for their families. And other people might actually be in an unfortunate situation where home is not the nicest environment. So it does differ people to people, but they want to be in a setting of their choice. And also that obviously most people want to die with dignity. They don't want to be in pain. They want to make sure that they have dignity, they have choice, that if they have any symptoms like pain or shortness of breath or other things, that's well controlled, and surrounded by people that they love and who loves them back. So that's sort of seems to be the characteristics of where people want to die.
Yeah, and I think that's a sort of really important view, actually, of healthcare and medicine. Because I think I was going to ask you a question about humanoid robots, with Tesla, and I think the South Koreans and Japanese are quite advanced in trying to make humanoid robots. But we can get sometimes distracted with sort of the flashbang of technology, but it has to match people's values and what's the purpose, trying to live a good life, maybe have a good death. That's the purpose, and it needs to be merged with that. There's no point having a Tesla bot that's a bully. And I think making sure that we're empowering people so that they're able to enact their autonomy in their decisions is important. Thank you very much for speaking with me and being the first guinea pig for this series.
No, thanks very much. And we should rematch so I don't get... That was an unfortunate loss.
I'll stop the hit. So that was a good win. All right, good. Thanks.
Thanks very much.